right, we'll go ahead and get started. I'm usually a pretty loud speaker, and can you hear me in the back? Okay. No one's ever told me that I speak too quiet, so that probably will not be an issue. Thank you so much for coming to this breakout session number 2, especially when it's been such a beautiful day outside and there is possibly rain coming. So I know beach time is very important right now. So thank you so much for coming in. My name is Tawny Causey. I am a genetic counselor and have been for 25 years. So yes, I started when I was 5, and that's why I'm so young. Yes. So what I'm going to do is give a little bit of information on genetics and how we are very much what we consider a reciprocal kind of relationship with the ARC and the services delivered by the ARC. So sadly, I have no financial disclosures. I always love this part when people list all theirs. I don't have any financial disclosures. I am an employee of Virginia Commonwealth University, so I am a Commonwealth of Virginia employee, and I'm also duly employed at VCU Health in Richmond, Virginia. No other big stock investments or anything that I have to disclose. So I was delighted when representatives from the ARC came and asked me to give this talk, and I really wanted to make sure that it was that I was going to hit the same kinds of goals that would be meaningful and relevant to attendees at the conference. So I really think that it's important to give this talk because, one, we share common goals. People first, always. It's not about the diagnosis. It's about supporting an individual to live his or her best life. Collaboration. We are all about making sure that we work as a team to make sure that families and individuals receive the support that they need. And again, we have a reciprocal relationship. So what do I mean by that? Many of the individuals and families that I work with in a genetics clinic who have a developmental or intellectual disability have an underlying genetic reason for that intellectual disability. And many of the families that you may work with in your professional capacity may come to genetics at some point, or families may be talked to by their providers or PCP, pediatrician, and said, hey, have you ever thought about going to genetics? So we often will see providers refer to us, and then we're often referring them back saying, you know what, these are support services that we think that you might find helpful. Assistive technology or speech therapy or physical therapy. So it's very much a circle in terms of where we are and how we can help each other. So what I thought it would be helpful, whether you were on the family side of the seat here or on the provider side of the seat, is to kind of give you an overview of what actually happens in a genetic session, why it can be helpful, what it can do and what it can't do. And just so that you have that information, knowing what's going to happen, take some of the mystery out of it. And it may make just inherently more sense why that may or may not be the right thing for your patient or for your family. So what we're going to talk about today is kind of the overview of the visit, common reasons why we might see families or patients seen in genetics. We're going to give you a little bit of high school biology, so taking you back to 9th or 10th grade, whenever that might have been, for genetics 101. No quizzes though. We'll talk about testing that you might have heard about or that might have been offered to your families or your patients. And we're going to talk about ways here in the Commonwealth that you can access genetics providers no matter where you live in Virginia. So fun facts, unless you're an identical twin, your combination of genetics is unique. You're your own person. People have 20,000 genes, but just when you think that's a lot, goldfish actually have more genes than humans do. So just as an interesting little side. So basically we're going to go who, when, why, and how through this presentation. So say your pediatrician says that you need to consider going to a genetics visit. Who are you going to probably meet with in that visit? And there's usually going to be 2 main people involved, and that would be the medical genetics physician and the genetic counselor. So the medical genetics physician oftentimes started out as a pediatrician, did the complete training for as a pediatrician, and then went and completed a special fellowship in medical genetics. So they do the entire kind of physical exam, just like you'd expect for any kind of physician. But what they're doing is very specifically, instead of diagnosing strep throat, for example, they're going to diagnose specific genetic conditions or consider the possibility of different genetic conditions. A genetic counselor like myself is not a physician. Most oftentimes we have our master's degree, and we work very closely with the medical geneticist. And most oftentimes we're going to be the people that families and providers talk with the most. We're the entry point to genetics. We're the people that you talk to most in the session, and we're the people that often follow up with you and give you results and so forth. So we're working very closely to get your medical history, family history, and helping to arrange any genetic testing. We all know all the joys of insurance and so forth, so we help navigate those waters. And then also making sure that families understand the results and what follow-up may be needed from there. Absolutely.
As far as where it says who and the medical doctors that are involved, do you just say, oh, I just want to go get
so we're gonna go through common indications, but the simple answer is yes. Many of the genetics providers will take self-referrals. So unless your insurance requires that you go through your PCP or whatever, you can say, you know what, my child has XYZ and I want to be seen by genetics. So we very much will take self-referrals.
Yeah, and on the website, on the Zoom.
Yeah.
Oh, I thought I hit admit. Okay. 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 So when I said we're the main point of contact, sometimes we can be the point of contact for months and months after your visit. Sometimes testing can take a while as we go through the insurance kind of odyssey. Sometimes just the nature of testing takes a while. And sometimes new things come up and it may be 6 or 9 months later and we're giving you a call because something has come up and follow up. So we, once you're our patient, you're always our patient. What we do is we take a family history and a medical history, because what we're trying to do is not only get information about possible diagnosis, but maybe what are the chances are for other family members to experience similar features. We help a family adapt to whatever the implications are of the diagnosis. Do they need additional information about the medical aspects? Or how about the psychological or familial impacts? So that's kind of the counseling portion of genetic counseling. And we're really kind of educators. We talk about inheritance, making sure families understand what are the chances for their child to have a child themselves with a specific condition, or what are the chances for them to have another child with a specific condition. Management, what kinds of doctors need to be involved to make sure that your child is getting all the resources they need. What available community or national resources there are, and if there are any research available, clinical registries and so forth. Probably one of the biggest things that we do, though, is we make sure that families are inherently doing what's right for them. Something called non-directedness. And what that means is that we feel like every family, every individual knows what's best for them. And what's best for family A doesn't have to be what's best for family B. And we do our best to make sure that family A, and whatever their decision is, whether it's to do testing or not do testing or whatever that may be, that they all have all the resources they need to make that decision that's right for them. So we believe fully in autonomy. Each person deciding for himself or herself. This is what we call a pedigree. So this is a really detailed family history. And what you can see is we draw squares for men in the family, circles for women in the family, and then we go through as many generations as we can. Some families know more than others. Some families are, for example, they're adopted and may not know particularly particularly more information about their family history. But what this can do is it can help us trace through a family how the condition might be inherited, how it might be running through a family. Now, this particular family history is really detailed, and we don't usually get this level of detail in a clinic. This is actually the royal family in Europe, and it's tracing hemophilia B, a type of bleeding disorder, through the different royal families of Europe. Again, most times we don't get this level of detail. All right. So what exactly are we doing in the medical appointment? When I keep saying medical history, what are we doing? So we're asking, what features led you here? Was it a heart problem? Was it an intellectual disability? Was it problems with growth, being taller or shorter than other family members? So those are the kinds of things that we're asking, in addition to just the regular things that we ask for all individuals at their stage of development. Family history, are there other people with the diagnosis? Or maybe not the diagnosis, but some similar features that maybe just haven't had a diagnosis before. We do that physical exam from head to toe. And then we're really talking about, based on your history, based on what we're seeing, based on the family, these are the things that we think might fit as a diagnosis for what we're seeing. Sometimes that is very straightforward. It's like A, B, C, and D, we think this diagnosis fits. Other times it's like, there's nothing really that's overwhelming here in terms of giving us a diagnosis. So sometimes we have to do some broad general testing to try and get some more information. And then we're always planning follow-up, whether that's follow-up with us, whether that's follow-up for testing, whether we say, oh, we heard a heart murmur today. Has anyone ever told you that? Oh, well, let's maybe get you over to cardiology as well. Because again, I wanted to make sure that everyone's on the team that needs to be. Generally, that visit is going to be about 60 to 90 minutes. So it's not a quick visit. It's not a 5-minute, open up your mouth and say, kind of visit, because we're going through quite a bit of information and time. So who is going to get referred to genetics? So what are the common reasons that physicians out in the community might consider saying, hey, your child or your family might consider benefit from genetic evaluation? So common things that any medical geneticist would see would be developmental delays or a diagnosed intellectual disability. Newborn screening results. So if you've had a child in Virginia, or if you're a provider that works with infants, then you know that little heel stick where they take a couple drops of blood from baby. They're looking for different kinds of genetic conditions that may not be apparently obvious just by physical features, but may need diet restriction or some other kind of surveillance to avoid more complications. So we will see patients for that. If there are problems with muscle tone, maybe a baby's muscle tone is a little bit weaker and he or she has problems sitting up on time or walking on time. Sometimes we'll see patients who were developing fine and then kind of got to a stage where they just kind of plateaued, where we weren't really seeing forward progress, or maybe they actually lost some of the milestones that they had previously demonstrated. Maybe they were talking and then lost some words. If there are unusual skin findings or markings, those are reasons that we will also see someone in genetics. Multiple affected family members. So sometimes we'll see someone and a child may be completely healthy, but maybe child's mom and aunt and grandparent and aunts and great aunts and uncles may have a specific condition. And so we're making sure that that child doesn't have that particular condition if that may impact his or her medical management. If a child's born with multiple birth defects, if a child's born, for example, with a heart problem needing surgery, or a kidney problem, intestinal problems, more than one organ being involved increases the chances of us finding an actual underlying genetic condition. Being shorter than what we'd expect for age, or taller for age, or then shorter or taller than what we'd expect based on the family, the parents or siblings. If hands and feet or limbs have developed a little bit differently. head size being a little bit smaller than usual or bigger than usual, one side of the body being bigger or smaller than the other side. Or if we say that a child just looks a little bit different from their siblings or their parents, if we, oftentimes you look at a picture and say, oh, you look just like mom, you just like dad. We can say, oh, you look like mom, but there's still some distinctive features that we're not seeing in other family members. And that may be a sign that there could be some underlying genetic condition. So does that answer a little bit about why some people might end up getting referral from their physician? Now, there's some other reasons that you actually might get referred to genetic counseling outside of the pediatric realm. And I'm not going to go into those as much because it really is not hitting as much for the target group here for this conference. But if you're over the age of 35, there's an increased risk for finding certain kinds of chromosome conditions in a baby. So you might be offered genetic counseling. If you've had 2 or more pregnancy losses, or if you have a family history of cancer that has occurred at an unusually early age, like less than 50, or lots of relatives with the same or similar types of cancers, or if one individual has had 2 or 3 different kinds of cancers. So these are all seen by genetic counselors as well. They're just not in the pediatric the pediatric specialties. They're in prenatal or they're in cancer genetic counseling. So what benefits can a family receive from a genetics evaluation? So for some cases, an explanation of the cause, knowing what the actual diagnosis is, and being able to determine what the chances are for their child to have a child with a similar condition, or if they're planning on further children themselves. More accurate information on short and long-term prognosis. So this can be a bit tricky. So for well-established conditions, we may have lots and lots of data about what to expect at 1 year, 2 years, 5 years, 10 years, and so on. But as we get more and more genetic test results that give us information about genes that we didn't know anything about, sometimes what we know about long-term prognosis is really limited. If you can imagine, sometimes we're seeing patients where there are only 10 reports in the world. And you can imagine we don't have a lot of long-term data in those cases. So unfortunately, families are learning right along with us some of the long-term information. When we get a diagnosis, we can make sure that we are ensuring appropriate referrals. We've had a number of children, for example, who may get a diagnosis and we'd say, oh, this is actually with a significant risk of cardiac rhythm problems, heart rhythm problems. No reason to have gone to a cardiologist before, but now we know we need to be on the lookout. We're going to go ahead and do a baseline cardiology referral. Sometimes there can be treatment options. More and more is learned every day about what we call kind of molecular medicine. So medicine targeted to the specific genetic change that is there. And sometimes research is more about just gathering information. Again, some of those really rare conditions, knowing more about these 10 individuals in the world who have these conditions. And fundamentally, it's about making sure that that family has the support resources for their child. Sometimes those support resources may be local. For example, Down Syndrome Association of Greater Richmond, fantastic organization that provides tremendous support to our families. But sometimes for these really rare conditions, it may be a Facebook support group is the only thing that's available for particular diagnoses and families. But whatever is out there, we try and make sure that we locate it. Yeah.
So you say those reasons covered by insurance?
So yes. So in most cases, even including Medicaid, Medicare, and so forth, the genetics evaluation, genetic counseling would be covered. Now we'll get into a little bit about testing because that's a completely different ballpark, but the actual evaluation itself, yes, is usually, that's not a concern at all.
I have lots of believe my father. So I'm just curious.
Autism is, yes. So autism is one of the most common indications that we do see along with intellectual disability in the clinics. So I have never had an insurance reject a claim for a medical genetics evaluation for autism.
There was, I know that there's testing that can be done to find out previous, like what you were born, like certain, like lack of certain nutritional nutrients, you were born. Like, that to-
Yeah, so we can talk a little bit more specifically about some of the what kind of testing we would do for baseline for individuals with autism specifically. Yeah. All right, so this is where you get ready to go back to high school. Chromosomes, genes, and all that. So these are the things that most people don't think about on a daily basis, but these are the things that I live and breathe. So if we go back to thinking about cells being the basic part of our body, and within the cells is our center of our cell, which is the nucleus, and that contains all of our chromosomes. And our chromosomes are made up of this whole strand of DNA, and this DNA actually codes for 20,000 different genes. And each gene makes a type of protein. Protein has some kind of function. Some genes make a protein that's also similar to many other genes in the proteins they make. And sometimes a gene will make a protein that no other gene can fill that role. So you can imagine that that can create some issues from a genetic standpoint. So we're going to kind of go at each step along this way. So if you think about your entire genome, so all of your genetic information being contained in a big book, right? Every individual has a total of 46 chromosomes, 23 pairs. So we get one of each pair from our mom and one of each pair from our dad. So half of our genetic information comes from mom and half of our genetic information comes from dad. So if we say, okay, the book is the entirety of our genetic information, then there would be 46 chapters. And each chapter would represent a chromosome. So chapter 1 is chromosome 1 from mom. Chapter 2 is chromosome 1 from dad, and so forth. Then we go to each sentence is the actual gene. So there are different ways that there could be problems with either whole chromosomes, so a whole chapter, like a missing chapter or an extra chapter, or problems with an individual sentence, problems with an individual word, or an individual letter. Oftentimes, genetic testing may start with our standard kind of chromosome testing. This has been the testing that's been around for the longest amount of time, and it's been around routinely since the 60s. Okay, so this is what you guys might remember: X's and Y's. Females have 2 X chromosomes, males have 1 X and 1 Y chromosome. And you can see these are numbered: largest, the smallest, and this last pair is what determines at least chromosomal gender, XX and XY. So with basic testing of the chromosomes, what we're doing is looking, are there extra chromosomes? Are there missing chromosomes? And people in the lab are trained to look at these tiny bands of light and dark. So if you talk with someone in the chromosome lab, they can say, oh, yeah, that's a 15 without just seeing it by looking at their banding pattern. It's amazing. I can't do it. They all look the same to me except for size. But that's what they're trained to do. So they can even see little pieces that are missing or extra under a microscope. So it's pretty amazing. However, you can imagine we're limited by what we can see with the eye and the microscope, right? So there's only so much that we can see with this picture. How is chromosome analysis completed? Well, blood is the most common one, but actually what got really common during the pandemic was the cheek swab, the buccal swab. And that saved a lot of people having to go in and go through the hospital laboratories to get tested when no one wanted to do that at the height of the pandemic. So lots of labs have validated now, and you can just do this easily through a cheek swab and actually just have a kit sent directly to your house, and you send it right back from the comfort of your own home. So chromosomes are actually divided into what we call a short arm or a P arm for petite and a bigger arm, Q arm. Q doesn't stand for anything, it's just the letter after P. So nothing glamorous about that. But it's a way of a chromosome lab telling you exactly where there might be a problem. So if they say 5p14.3, they know to go to chromosome 5, and they know to go to the short arm, and they know exactly what band to go to. So if you get a chromosome result, you might see that level of detail. You can also see problems with a whole extra or a whole missing chromosome. For example, a whole extra chromosome 21 would be what we call Down syndrome or trisomy 21. And that extra chromosome can cause problems like with the heart and so forth. So if we got a diagnosis, we want to make sure that individual had gotten an evaluation by cardiology to make sure that we weren't missing anything that would impact health. So I mentioned that chromosomes can only tell us so much. So what has really replaced basic chromosomes in most cases is the microarray. And this is actually the first line of testing for individuals with autism. This is where we often start. So the microarray is a way of looking at all the chromosomes all at one time. And not only is it just looking for whole extra missing chromosomes, it's looking for small, really small or large portions of chromosomes that may be missing, which is a deletion, or extra or duplicated. Okay, so this level of detail is what we couldn't necessarily very easily see on the regular chromosomes. So what we can see here is that if it's even just a missing or extra portion within one of those bands, that can be really hard to see. The microarray can tell us that. So it's giving us really good resolution down to very small areas of the chromosome. So sometimes we'll get information from an array that's a very common condition. We say, oh, this is a well-characterized condition, and we can give this family lots of good information. Sometimes it'll be a condition we say, you know, it's known, but we still don't have a whole lot of information, so we may not have long-term prognosis. And other times we get what's called a variant of uncertain significance. So it sounds kind of as yucky as what it is, and that we're saying there's a difference here, but we don't know whether it's relevant or not. It just has not been reported enough in the medical literature. And that's a really frustrating cause for families. Families like, I just want an answer, and we're telling you, well, this may be the answer, it may not be, and we have to wait for more time. And that's the last thing you want to hear as a family. So what the microarray actually can do is it's not looking at the individual level of that gene. So it's not going down to the sentence in that chapter. What it can tell you is maybe a paragraph in that chapter may be affected. And in that paragraph, you can say, oh, well, I know these 5 genes are in that paragraph. And then you go and do some research and see, oh, are those genes actually associated with some of the features that we're thinking of in a particular condition. So it's a little bit of research and detective work to see whether what we're seeing really is going to be useful and helpful and fits with what the family has given us in terms of information. So what if we do this microarray, this kind of baseline testing? What happens if it's normal? Well, in some cases, the medical geneticist will say, well, let's go ahead and do very specific testing for this one gene or a panel of genes. Gene testing is more specific because, again, we were kind of looking at the level of paragraphs in the microarray, and now with gene testing, we're looking at the level of sentences and letters. But the problem is that you have to know which sentence to go to. Imagine how many sentences you have in 46 chapters. You can't just kind of say, I'm going to look at all the sentences. That's kind of creates a lot of hay in that haystack, for example. If the genetic condition that they're thinking of has just one gene that causes it, that's a very straightforward test. It's usually relatively inexpensive in quotation marks. But if the genetic condition actually has a lot of different genes associated with it, then it may be a panel of a number of genes. So that's where we start to play out, what is insurance going to cover? How much does each lab charge for this kind of testing? And what lab can we choose that's going to give us the best test for this patient with the least out-of-pocket cost for the family? Not all private insurance companies have the same policies for genetic testing. Not all the managed care Medicaid have the same policies for genetic testing. And that can be really frustrating for a family when we tell insurance, look, this is the medical guideline. This is what we're supposed to be doing. And they'll say, well, that may be it, but we don't follow that policy. And that can be really difficult. Some labs have a really generous kind of financial aid policy that if you just provide, what your salary is and how many people live in your household, they'll often give you a decreased price. But we all know times are tough right now. People don't have $100 just laying around. So that can be really challenging for insurance to dictate sometimes when we can get an actual diagnosis or not. All right, so we've done the chapters and chromosomes. Now we're at the level of the gene. So when we're looking at the individual sentences, what we're doing is seeing whether that sentence or those words make sense. So the gray cat ran down the hall. We all know what that means. It makes sense. That's kind of that's what we say is the reference. That's what we're going to look at in comparison to the test result that we're going to get. So sometimes it could be the gray cat ran down the ball. Well, we can kind of understand what that was trying to say. Not exactly right. But that may be enough of a change to actually cause a diagnosis. Or how about the gray-green cat? Now we've got a whole word in there that doesn't even belong in there. Or the gray ran down the hall. Now we're missing a word. So there can be a variety of different changes. The one that usually is the most significant is this one. It's called nonsense. And if you imagine these sentences trying to give directions, think about a cookbook. If you had a list of directions and the first direction said stir, and that was it. Stir what? What are we supposed to do here? That's a problem for a gene. It says, okay, we're supposed to make this protein, but the directions are incomplete. And so in that case, usually no protein can be made at all. So when you get that kind of genetic change, usually that's a clear cut, this is causing the diagnosis. So again, these are the different information that the genetic counselor is getting that will pass into the family as to whether we think we have information about a diagnosis or not. So what happens if we get testing that's positive? Well, we've got our diagnosis. We have an exact genetic cause identified. The family can then get accurate information about maybe other common features that we need to maybe rule out or that hadn't been recognized, inheritance, general information about prognosis, and then the appropriate referrals. So with genetics, unlike for, strep throat or something, that maybe just one member of that family has strep throat, with genetic conditions, there can be implications for other family members. So genetic conditions can be brand new to one individual. That's what we call de novo. So it happened brand new in that individual, and it's unlikely to happen in any other family members, but maybe for the individual who has the condition, he or she may be at risk to have a child with that condition. Some changes are recessively inherited, meaning both parents are carriers, they're healthy, but one of their genes isn't working, they both happen to pass on the non-working gene. Some changes are dominantly inherited. So one parent has the same condition and passed on that same gene that causes that condition to the child. And some are located on the X chromosome. So whether you're male or female will dictate what kinds of features that they may have. Yes.
Genetic testing's done, people see which it was inherited from.
So that's a great question. So let's say we get a result that, so we said this gene is the ABCDEF gene, okay? Then we'll know exactly what chromosome that gene is located on. So automatically we'll know whether it's an X-linked or not. So that puts it in that category. If there are two changes, usually that means that parent has one copy and the other parent has the other copy. If there's just one change and it's not obvious whether one of the parents actually has the condition, we'll often go ahead and test them and make sure that they don't have a condition that was previously unrecognized or undiagnosed. So sometimes it's very clear cut, and other times we get a result we're like, that's really not fitting the family history. What is the significance? And so sometimes we'll do more testing. Yep. So in those cases, what we're mainly focusing on is if we can get a clear-cut result that we know is positive and it's a true diagnosis, and we don't have to go back to looking at parents or siblings and so forth, then we can very clearly tell you what the risk is for your child to have a child himself or herself with that condition. Most labs have, thankfully, started free parental testing. So once you get a result in a child, oftentimes they'll test the parents for free just to clarify everything in terms of whether a parent has that gene or not, because that would just be awful for parents to have to pay additional money just to do that. So it's all considered part of the testing process. So depending on what the condition is, these are the kinds of charts that I would show with a family. So I would describe, okay, if both parents are carriers, and this is the child who actually has the condition, so there was a 25% chance that they were going to have a child with that condition. But if they have more children, their child could be have the same condition, or maybe their child would be a carrier like themselves, or maybe that child won't be a carrier, won't have the condition. So we go over that information so it's very clear for the child and for parents what the chances might be for other individuals. Same thing for dominant. In these cases, if mom has a condition or dad doesn't matter, then there could be a 50-50 chance they're either going to pass on the gene or not pass on the gene. Kind of like flipping the coin. And then excellent could be really complicated because not only is it a matter of whether the parent actually passes on the gene that causes a condition, but then it depends on whether the child is a female and may be more mildly affected or unaffected, or whether the child is a son and may have more significant manifestations than what mom does, because women have 2 X chromosomes. So if they have 1 X chromosome with a gene that's not working very well, they have another X chromosome that usually has a working gene that makes up for it. Men have 1 X and 1 Y. So if they have an X chromosome with 1 gene that's not working, they don't have another gene on that Y chromosome. So they're going to tend to have more significant manifestations than what their mothers would. Yeah.
So I have 2 boys who have an X chromosome. We're connected to people internationally with this syndrome, but there are a few females who are affected by it too.
Yep.
I've never quite understood that. Can
Yep.
you explain how that happens?
Absolutely. So we used to say that excellent conditions that women were carriers, and that actually is probably really a misnomer. So a classic example of this would be like a disorder like hemophilia, where some women who are carriers bleed. What happens is you might say, okay, women have 2 X chromosomes and men have an X and a Y, but how are they able to survive when they always have 1 less X chromosome than women? And the reason is very early in embryonic development. In women, 1 of the X chromosomes is always inactivated in every single cell. So imagine if you had, this was the X chromosome that had the gene that was working, and this was the X chromosome that had the gene that wasn't working. And imagine just by random chance, more cells with the working X chromosome gene got deactivated. So a lot more of the working X chromosome that's activated has a non-working gene. There's going to be a lot more cells that have a non-working gene, and those women are going to be more likely to have features of the condition. Whereas if you had women who had like a 50-50 split, which is what generally happens, 49-51 or whatever. Or someone who had a split that it was 80% where the X chromosome network rate was left on, and the one with the non-working gene was deactivated. That person would be unaffected as well, and wouldn't know until they had a son who happened to have that condition. So that's one of the mechanisms that can happen. The other mechanism, sometimes we'll actually go, and that's called X chromosome inactivation studies. There's actually labs that will do that and tell us that. And sometimes we do that and say, oh, it's got to be X chromosome inactivation, and it's not. And in those cases, we say there must be some other gene that's interacting with that gene that we just don't know enough about, that's leading to some women having features that we would expect. But we don't automatically dismiss nowadays any X-linked condition as just, oh, you're a woman, you're not going to be affected. We've learned to think much more broadly. Mm-hmm. Does that help at all?
Yeah, I'm like so not science minded to like hang by a thread.
Okay. So what if you go through all this so far and genetic testing is negative? Well, there is more comprehensive testing available. It's something called whole exome sequencing or whole genome sequencing. And this is where they're literally looking at all 20,000 of your genes at the same time, okay? That's a whole lot of genetic data, right? So it takes a little while. It takes a couple months to get those results, and it's expensive. And this is one of those cases where not all insurance policies have the same coverage. Some, again, even for some of the managed care Medicaids, some will cover it and some categorically say, no way, we will not cover it at all. So if you pay out of pocket, some labs will give you a break and say, oh, it's only going to be $3,000, only $3,000. But insurance actually gets billed $7,000 and up for this test. There's a lot we don't know. So I mentioned that every day we kind of learn about genes that we really didn't think were causing any genetic conditions, and now we know that they do. So we can sometimes get results where like, I don't know what this is. I don't have long-term information on that. And so it may be an answer, but it may be an incomplete answer for a family. The other thing that can be challenging is trio testing is most informative. Trio meaning usually mom, dad, and a child would be the most informative. And the reason for that is particularly if the child has features that parents don't, what you're doing is using parents as kind of controls and saying, oh, we found this genetic change in a child and neither mom nor dad has it either. It's new to the child. Maybe this really is the explanation for the genetic differences. But if you say, oh, we've got this change, but mom has this change and she has no features. She doesn't have heart problems or intellectual disabilities. So maybe this is not relevant. So trio testing is most informative. But the problem is we all know trio testing is not always possible, right? We don't always have parents, or we have a child who was adopted. So we don't always have that capability. So there are some limitations with it. Whole exome sequencing and whole genome sequencing often get thrown around interchangeably in the medical community, and they're really not interchangeable. Most people are doing what's called whole exome sequencing. So if you imagine this orange is the entirety of your genetic information, it's the whole book, okay? What we're doing with whole exome is just doing a little slice of that. But in that slice is where the vast majority of human genetic conditions are caused by in that little slice, okay? So whole exome sequencing is the most clinically relevant comprehensive testing that we can do. Whole genome is coming along. It's not far from being the gold standard. But if you think about, we don't even know what everything in that one orange slice does. You can imagine there's a whole lot in that whole orange that we really don't know. So we can get results from exome that we don't know the significance, and we certainly can get results from genome that we don't know the significance. And I've already kind of gone through this information. So just FYI, if you had parents and a child and you went through this whole exome sequencing, you probably get a definitive diagnosis in about 30% of cases. Some labs will quote up to 40%. Whole genome sequencing, so not just doing a slice, doing the whole orange, maybe gives you another 5 to 7%. That's why we say right now it's not quite ready for prime time, because there's a whole lot of extra stuff that you're going to get to that extra 7%. And then what if we get a negative whole genome or whole exome? It still doesn't mean that it's not a genetic condition. It just means that we don't know how to recognize it yet, or we don't know how to test for it yet. But it's still the most clinically comprehensive testing that we can do. No lab covers whole genome sequencing at this point in time. Well, there's one lab, but we don't routinely use them. You can read the subtext of that. But again, it's coming. All right, so how can you be seen by genetics? So this is not just, this is for anyone in the Commonwealth. So let me know, I've got information here for everyone. So if you want for this neck of the woods, so Hampton Roads and so forth, that would be Children's Hospital, the King's Daughters, Dr. Regano. And what's also helpful is that they have an email, genetic counseling at chkd.org, that if you have questions, you can just email them before you even have to make an appointment. So let me know if I can I switch the next slide to the next? UVA, if you're more in central region, UVA pediatric genetics, they don't have an email, but Dr. Wilson and Dr. Peruka, they also do that special newborn screening management as well. Yeah.
With this kind of stuff, so we're linked right now for my daughter with a geneticist neurologist at CHOP.
Okay.
Because when she was first diagnosed, it was subjective symptoms only. But since then, she was involved in research, and now they have a test. We were one of the ones that our insurance said this isn't valuable information you don't need to know. And I'm like, well, we kind of do.
Don't you love insurance? But when insurance makes that determination for you, yeah.
So, like, for me, it's important. She's 15 now. So we're getting to a point where, you know, we're being told, well, you really should transition to an adult geneticist and an adult neurologist and adult all of these other things. But we've been with her neurologist geneticist, who is one of the leaders across the world in this disorder, since she was 2. And so at 18, it's going to be really hard for me to want to transition for
absolutely,
because I live in the Culpeper area. So how do you go about making that transition? And they have no idea, I can guarantee you, about her disorder, because there's 200 people in the world with this disorder. So how do you go about making that leap as a parent?
Absolutely.
To kind of get yourself in somewhere to get them.
Well, and especially when you've got the care team that you inherently trust. They've been with you on this journey. Yeah, and you've been on this, they've been with this journey with you the whole time, and you trust them and so forth. So what I usually do is I start with for the neurologist, I'll speak to neurology first. I would ask that neurologist that you work with, the pediatric neurologist, if there is an adult neurologist in the Charlottesville area or DC, whatever you want it to be, that perhaps they feel most comfortable with. Now, will they know everything about the condition? No, but if they feel comfortable with that level of knowledge, then neurologist to neurologist, they can share the information. But that's where, you know, just picking a neurologist out of the phone book wouldn't be the same thing as, oh yeah, I know so-and-so, they, you know, were in medical school with me, I trust them implicitly. That goes a long way. From a genetic standpoint, you know, we're, I think, a little bit more used to dealing with conditions that aren't well known. And in this case, the genetics community is fairly small. And I guarantee you that Bill Wilson and Christina Peruka at UVA probably know at least half of the geneticists at CHOP very well. And all it would take is a matter of, okay, whoever your geneticist is, it's Sally at CHOP. Sally calls Bill Wilson and say, you know what, we want to transfer, you know.
Are they doing this pediatrics again? So is that
No, they see adults. So this is not a children's hospital. So they're allowed to see adults. Yep. Children's Hospital, the King's Daughters won't see anyone above 21, but UVA will see throughout the lifespan.
You go to battle for other things.
Yeah. Yep. Yeah. they're in peds, but they'll see throughout the lifespan.
Thank you.
Same thing with ECU genetics. We're based in the Children's Hospital, but we'll see it throughout the whole lifespan. And then this is Rona for Carillion Clinic, Dr. Doherty. Now, also, I should say that UVA also does a loop through Southwest Virginia and Bristol once a month or every other month as well. So, but those clinics obviously book up pretty quickly because they're only, every other month or so. And then, of course, Children's National in DC. I always say be careful resources you access. So you guys know, if being parents of children, that you want to make sure that you're getting accurate information. Anyone could post on the internet. You want to make sure that you're getting clearly vetted medical information that is family oriented, not just for the physician, but family oriented. And then questions, and then I left enough time for you guys as well. So questions, yeah.
I have two. One for this area for adult genetics.
So VCU would be one area for adult genetics. There is also, and I don't know anything about this individual. Someone told me that there's a medical geneticist at Portsmouth Naval, but I don't know if that individual will only see someone who is like TRICARE or through the milk, TRICARE. Then I would start with Portsmouth Naval. I don't know that individual's name, but they've been there for a while.
And another question, as far as after you get the diagnosis, do you have to turn results over to the insurance? Because I know with the fraction, there was discussion on.
Sure.
On that.
Right.
That fraction, and then I didn't have to turn it over to insurance. I didn't have to turn it over, but like if it comes out negative for autism, but my son's getting services for autism.
Right. So in the case of autism, it's not going to negate it's not going to take away the diagnosis of autism. It would perhaps give you an additional diagnosis in addition to the autism, but you would never get rid of the autism diagnosis. So we don't have to worry about that. If insurance is going to pay for your testing, they have a right to request the results. So the only way to get around that is to actually pay out of pocket. Yeah. So many times when we talk with children or parents of children who have some kind of intellectual disability, they have other features that are also going on that will impact their ability to get life insurance. So it's not always the genetic testing that's going to inherently affect their ability to get life insurance. It may be their other coexisting conditions, intellectual disability, congenital heart disease, and so forth. But we do talk a little bit about that when we're doing whole exome sequencing, because sometimes you can get a result that gives you something for an adult onset condition that you weren't even looking for, but is important enough for them to actually say, well, you need to know this, even though it won't affect you until probably 30s, 40s, or 50s. So we do talk a little bit about that. Yeah. So at that point, if you're 30 years down the road from life insurance, if you're talking about a newborn baby, most people don't take out life insurance on a newborn baby necessarily. It would depend on what they're asking for. Mm-hmm. It depends on what insurance company you're applying to, and it wouldn't be this kind of testing. Oftentimes it's like cholesterol and stuff like that. Yeah.
And it would depend on when you.
Yeah, it also depends on your age. So if you're like 18 and they presume you're probably a healthy 18-year-old versus you're 60 and you're a smoker kind of thing, and that's going to be a whole different ball of wax, right? No. And luckily, no. Luckily, they cannot do that. There's actually been laws. Yeah. Right. Yeah.
So a couple questions. One of the easier ones probably so we're a provider, customers. Did you say one of the tests was like $100? Like, so I'm kind of wondering as a preventative, just the docs test every
No, no, none of the, there's, sometimes your copay may only be $100, but there's no genetic testing that is that cheap.
Preliminary screening tests,
Chromosomes, like chromosomes themselves, probably cost $500 to $700. Yeah, so, and then chromosome microarray goes up to $1,500 to $2,000. And then you can get some single gene testing for $600 to $800, and then some panel tests can cost $2,000 or $3,000. Yeah.
when you say take Medicaid or PCPs, are they jump to this and say, okay, I can get this done, or is that us to know, we need to ask for it?
So in terms of, we don't recommend that a PCP or pediatrician be the baseline to order this testing because of the complexity of ordering it. So we really suggest that they refer to a genetics provider wherever you may live, so the genetics provider can then order it. And because they also know which labs are the most affordable and how to kind of work the insurance system. Sometimes it'll be the family that says, hey, you know, I heard about genetics, and did you ever think about referring us to genetics? So it's completely legit for you to say, hey, I think this might be worth it. What do you think? And if they say no, you still can go on and do a self-referral to genetics without a problem. Most providers will see a self-referral. Okay.
So I have an art title I'm reading. I want you to tell me, how does this affect them?
Okay.
Okay. Google's DeepMind AI is 3D structure to every protein in the science. Just came out. Apparently, predicting the shape of proteins, how they fold, and all that's really hard for the real type problem. Right now, Google's DeepMind AI is doing it very fast. And I think it's not open source, but allowed to be used for non-commercial applications for research.
Okay.
How does that affect that?
So when they are trying to, when they find a genetic change in a gene that they don't know the significance of, they will go through, it's what they call variant classification criteria. And one of them is, okay, what is that change expected to do to the protein? Is it going to eliminate the protein? Is it going to change the shape? Is it going to change the way it folds? Is it going to change whether it's hydrophobic or hydrophilic? So those are some of the things that they take into account. It won't change much of what we do because we can clarify the significance and changes about lots of other things other than just protein folding and shape and so forth. If they're only allowing it on a research basis, most genetic testing is done on a clinical basis, and that's insurance dictated. If you want clinical testing, it has to go through a CLIA approved lab. Whereas research is not CLIA approved. So, and most research often is free, right? It's just done through a lab that is investigating a gene. Might have been how your particular geneticist or a neurologist had a particular interest. And so they were able to do that testing for free. And sometimes it takes a little bit longer. It may take 6 months to a year to sometimes get those results.
My son got to do it after it became clinically available.
But for your daughter,
GDX,
G-
is that a good one? Because that's who we went through.
GenDia, that's probably one of the 3 biggest labs in the country that's used.
So
Does that-
my daughter was,
Mhm.
yes, research. My son, he became 18, decided he wanted to know.
And then
he
could
was a carrier,
clinically get it just
and
very
yeah.
straight. Yep.
He
Yep.
went through genetic counseling and
Oh, good.
we
So,
had him do that without, independent.
so
of
he
us,
can make
and
his choice of
he
whether,
could make his own decision.
absolutely, perfect. Yep.
It was very, very important.
Yep.
And my daughter's 18 now, well, 19, she wants to go through the process.
Yeah,
Yeah.
absolutely. So does that help you?
I recommended siblings, they've been exposed for years, so they were very young, and, when they were young, they wanted to know, of course, they didn't know what that meant, but, when they become age, I think genetic counseling.
I mean, it could just help to lay out kind of in a balanced, what does it mean if you do it? What does it mean if you don't do it? What if you're a carrier? What if you're not? And just so they're,
And really
seeing.
understanding that your sister isn't necessarily what
Every
your child
experiences.
would
Yeah.
experience,
Yeah, very much so.
I guess what, and then I started going on a radical with art, of course, lots of people was in my head, but I'm immediately going, how does this affect facilities? Like, it's not like proteins, sometimes they fold together, or they match and all that, and they were able to basically predict the shape based on abnormalities that may proteins, and about 2 years research, you know, oh, we got this. The AI says, build like this.
Yeah.
Just dealing with symptoms.
Right. And that's molecular medicine. Yeah, absolutely. Yes, it's in its infancy, and it's very much, cancer is the place where molecular medicine has really taken off, where based on the genetic change, they target the medications specific for that genetic change that cause the uncontrolled cell growth in the tumor. So that's the place where molecular medicine has taken off so far. All right, I want to turn it over to you guys to talk a little bit about the Genetic Navigator.
Sure. So I'm Jen Reese. This is Lisa Bouchard. We both work at the Family Network at the Partnership for People with Disabilities at ECU. And we have a program called Family Navigators, which are parents and caregivers of people with disabilities who are there to help others. We have lived experience, we help others with emotional supports, systems navigation, and finding referrals and all different kinds of supports. So we've actually, over the past year, we sat on a committee where we talked about what are the barriers to genetics diagnoses in Virginia, and we've come up with what we call the Genetics Navigator Program, which is a subset of our family navigators who are parents of children or caregivers of people with a genetic diagnosis who have been through this process and have now had extra training to be able to help others. So Lisa and I both have children with genetic diagnosis. My daughter's is de novo, so it's not inherited. She's not going to pass it down to anybody. Any other kids we have will not have this, less than 1% chance of having the same thing. And one of the things I wanted to touch on, we said how she started genetic testing when she was born. We didn't get her official diagnosis until she was 4 because they hadn't discovered that gene. So we always said we had to wait for science to catch up to her. So there's lots of stuff they don't have answers for yet. And, you know, she could have 3 more genetic diagnoses 10 years from now. So
We don't know.
yeah, so we've always been told, like, she has a genetic epilepsy. So we've been told that if you don't get an answer, to go back to genetics in 3 to 5 years because they'll have that much more science behind it. But we handed out flyers. There's an email and a phone number. And so if there are people who are either looking to find answers to genetics or have gone through genetics and now need supports, and we have lots of resources, and there's lots of online indicators, the rule of 2s. There's a bunch of different resources that we have of things that red flags that you can identify to take to your pediatrician if you do need a referral and say, look, we have these things, and this is why we need the referral to genetics if your provider isn't on board. So we're just an extra support for folks either looking for or who found a genetics diagnosis. So, and we have a table out front too, the green tablecloth, and we provide support throughout the whole state. I'm in Northern Virginia, and this is in Southwest. So.
Okay. Thank you. Thanks, guys.
Thank you.
I'm sorry. If I heard the name, it's been over 5 years ago.
Yeah. So NY and H is